Thanks.
All right. I'm going to give everybody just a minute to get logged in, and we are going to be having an amazing webinar for you guys today. First of all, happy leap year. This is such an exciting day. And I'm also very happy because Ted with HMR, you guys know, our dear friend, he's coming in later at the end of the webinar because we're not giving away just one lucky winner who's going to get 4 bags of freshly roasted coffee, but 4 winners today. So very excited about that. And we'll have Ted pop in towards the end. But we have got an amazing webinar planned. I highly encourage everybody to ask their questions. You can put those in the Q&A box, and we're going to have Kyle kind of monitor those for us. And then later, you're going to meet my amazing partners over at OnPoint Legal Nurse Consulting, Fox-AE, and then also HMR as well. So let's go ahead and get started because we have a lot we're going to cover today. I am thrilled because we have our friends back, and Kyle is back with us, you guys. You always know it's going to be a good webinar when you have your friends here. Let me go ahead. For those who do not know Kyle yet, he's actually the Chief Revenue Officer for HMR, and he manages all of the sales operations around the country for the organization. He currently oversees a lot of the daily operations of the business, which has been doing business in over 40 states where they currently operate. And he has been with HMR since 2012. He's been in the medical funding space for well over 16 years, and he has had the opportunity to fund several thousand cases with a primary concentration on funding TBI, as well as catastrophic injury cases for plaintiffs who are uninsured. As you guys have heard, me and John Romano, we have stressed the fact that we love working with this company. Again, you're going to hear a little bit more about HMR later, but you guys are going to hear from our amazing speakers today. I'm going to go ahead and hand it over to Kyle, and I hope everyone has a wonderful webinar.
Awesome. Thank you so much, Ginger. It's great to be back here. We've done a number of these webinars, and they always turn out to be fantastic with just a ton of good information coming out of it. Today, we hope is going to be no different. We're really excited. We're going to be touching on something that is a huge part of brain injury, and that's the post-acute space and rehab and getting people actually the treatment that they need once they have kind of identified that there is a brain injury there. So we're really excited to have Pat and Jimmy with us. I'm going to do some introductions, but we'll do a little housekeeping first. We're going to run the format just like we have in the past. We really want to encourage as many questions as possible to kind of keep it an interactive discussion. So what we'll do is ask you to post the questions in the chat box, and we will kind of ask them as we go. We'll try not to interrupt the program that much. That way we can keep a good flow of the information coming, but we'll try to get to everybody's questions. But again, we really encourage everybody to ask questions in the chat, and then we'll get to Pat and Jimmy to get them to answer it. So with that being said, again, I'm with HMR. A lot of you are familiar with how our company works, and we're really privileged to be a part of Connectionology and such a wonderful organization. I'm going to do some quick introductions for our speakers, and then we'll turn it over to them and get them started. First up, we've got Pat O'Reilly. Pat is a healthcare executive with extensive experience in developing brain injury programs in new markets. For over 20 years, he's facilitated the opening and acquisition of programs across the country for several major rehabilitation companies. He has a dual degree in marketing and management from Baylor University, then began his career working for 10 years developing strategic relationships among healthcare clients in varied specialties to improve market efficiency. However, Pat found his passion in brain injury and has worked for the last 2 decades leading successful national post-acute development teams for major brain injury rehabilitation organizations. Prior to co-founding Resilient Life Care, he developed and trained marketing teams in several major Texas locations and Ohio. While training national marketing teams, he instilled his personal vision for helping persons with brain injury. The philosophy is that his work changes the lives and motivates him to keep working to this day. During his time away from work, Pat enjoys surfing, cycling, and spending some time with his family. I will now introduce you to Jimmy, who's going to do the majority of our speaking today. This is Jimmy Moody. Jimmy has nearly 20 years of experience as a clinician, educator, and organizational leader. He graduated as a physical therapist in 2005 and achieved the neurological specialist certification from the American Board of Physical Therapy in 2011. He has served as a research fellow in biomedical engineering group and as an adjunct faculty for doctoral physical therapy programs and on the district executive committee for PT governmental affairs in Texas. He's presented to various healthcare disciplines at the local, state, and national levels on assessment and treatment of neurologically involved persons. Additionally, Jimmy has held his brain injury specialist certification since 2011 and become a trainer in 2016. He's previously held the position of CEO for an inpatient rehabilitation hospital, regional director of clinical operations in Texas, and currently serves as the senior vice president of operations for a national post-acute brain injury company. Outside of his work, he is a dedicated husband, father, and enjoys learning, exercising, and taking in the moment. Guys, we can't thank you enough for being here today. This is going to be a super important topic, and we're excited to jump into it. So with that, we'll turn it over to you all and let you get started.
Great. Thanks, Kyle.
Thanks, Brian. Yeah, so Pat and I agreed that we're just going to run with this. It's going to be a lot of fun. And if it bombs, then we're just going to bust out into some breakdancing moves and try to keep entertaining the group. So just a heads up here. I'm going to start sharing my slide deck so everyone can see that. And Pat, you can see it, right?
Not yet.
Okay. So today, like while we're going through the slides, there's a lot of content that we're going to cover. We basically want to give a presentation of what it's like for the brain to go through the trauma that it could at the initial injury all the way through the ER, through the different continuum of care, and then also through the post-acute brain injury setting, such as where we work. All right. How about now?
Yes.
Got it?
Okay, we're good.
Sweet. All right, very good. So as mentioned, those are our names. And these are the objectives. So we'll go over some common signs and symptoms of brain injury, specifically traumatic brain injury. We want the group to understand the different levels of care in TBI rehab, along with understand like common evaluative and diagnostic tools that are used in brain injury, and then common treatment options for people with brain injury, whether they have a diagnosis of a mild or moderate or severe brain injury. And also we kind of looked at challenge some of the current thoughts behind brain injury care and labels that are placed on it. And then also kind of integrate in some documentation practices that will also show up in medical records throughout the start to finish experience. So just a real quick overview of traumatic brain injury in this country. You'll see the majority of them, almost 80% of them, fall within some type of trauma to the head. So falls, vehicle accidents, struck by some type of object. It could be something that falls off and hits somebody. It could be, in an accident itself, but some type of trauma that hits the head, and then assaults. And then you've got another percentage down in the sports recreational area. So since our focus will be mostly on accidents that obviously are not planned and can be catastrophic, we're looking at motor vehicle accidents, falls, being struck struck in the head by something. And usually what happens at first moment, if you can just kind of imagine along with us, that the skull and the brain are going along as expected, and then some insult happens. And none of these injuries are intentional. Most of the time the accident is unexpected. It's a very short amount of time to even process what's happening. And then now you have first responders at the scene and somebody's assessing and making a determination. So there's a lot of things that happen and get decided very early on. And so that's the first thing I think it's important to consider, is not just like the journey of the brain through the trauma, but all these things that are surrounding it as it goes. I mean, the stress levels at the scene of an accident. Am I okay? Am I not okay? I've got people asking me questions. And then as you go further on down the continuum, similarly, you've got your own personal crisis and distress, and maybe family and other factors and variables that come into play that kind of put a lot of pressure on the rehabilitation of the brain. And so I think that's important to consider as we go along the continuum. So if we put our focus back on the brain and spotlight, what's basically happening, you might have this, again, an accident, just using this roadside motor vehicle accident as an example. And we got photos to better represent this. Is, you've got the brain that's sitting inside of a skull, and the skull is obviously a bone, and then your brain is more of like a soft material, and it can shake around within the brain, can shake around within the skull, like forward and back, and that's the coup contra coup. Or even you'll have these torsional and rotational forces that happen within the skull, and then just some type of trauma where something could hit the skull, and you've got just blunt trauma right at the local area of where the brain might get hit. And then that could start the injury, and then you have these sequelae of things that can happen. You start the brain is smart and dumb in the sense that, it's obviously, the epicenter of our experience, but it also starts to do things to protect itself once it experiences trauma. So you'll start having neurochemical changes, like this cascade of neurochemical influx or even shutdown of certain neurochemicals, neurohormones, and the brain basically wants to try to protect itself to survive. So you might have these shutting down, kind of like powering down of a computer kind of experience inside the brain, because its goal is to survive. So it starts to minimize its energy expenses. So that can show up in different ways. It could show up in a loss of conscious. It could show up in that attention is not given to the surrounding, and it's focused on just survival mode. You have blood flow changes, oxygen levels can change. So again, just lots of little things could just start happening that they don't appear to be happening on the outside, but are already occurring within the brain itself, just based on its natural design and reaction. To demonstrate the trauma and probably like, the movements that could be happening in the brain, these images will show some of this forward, back, side to side, torsional movements, and then a brief video here that definitely brings home the point. Hopefully that'll pull up. Just giving a visual of the motions that could happen inside. So if you just kind of keep that video in mind as we go through the next several slides, again, I think it's clear that you've got these movements, like these forces that are taking place within the skull itself. Now what's happening outside the skull, to the person, that's a separate part of the conversation, but for now, just focusing on the brain. Your brain is it's a 3-pound mass. It's very compact, it's thick, maybe like a cheesecake, but it would be overly simplified to say that it's, the consistency of a cheesecake. So you've got, again, about a 3-pound mass. It consumes about 20% of our water intake. So it's got a lot of need and nourishment demands on it. So obviously the most important organ, arguably, in the body. But it's also relatively delicate because it's so intricate. And visually, you can see these lines, which are veins. And then on the inside of the brain, you see all this like little river systems of arteries and veins to go with that. So a lot of very specific anatomy points that are at risk for damage or disruption when you have a traumatic event like a traumatic brain injury. Another point that's equally important to consider is on the skull image, you can see now this is pretty much the brain's been removed, and you can look down and you can see the surfaces and just the very specific contours of all these little sections that are sitting underneath the brain. And why that's important is because the brain underneath on the underside is sitting like very snugly in all these little crevices. So if you start having these forces, forward, back, side to side, there's going to also be call it micro trauma, potentially underneath that. And that could correlate with symptoms that you might see. The other thing that's really hard to visualize is that the surface, the inner surface of the skull, not the outside, but the inner surface, is not a nice, smooth surface. It's actually very rough. And it's like that for a reason, because it holds, you know, other you know, tissue on it. So it has a purpose to it. However, it's also rough. So like sandpaper, and that's about accurate, that it has this roughness to it. So again, inside trauma, back and forth, hitting these little crevices, rubbing against a, you know, a very scratchy surface, just again can cause different types of internal damage that sometimes are not even observed in an image, for example. And to belabor the point, if you really zoom into the space in between the brain and the skull, you know, you're talking centimeters. It's very small distance between these two. So there's not a lot of, you know, wiggle room, so to speak, when the brain can kind of move around a little bit. There's not a lot of space. But this space within here, I mean, this whole area is known as the meninges. This little center section is the arachnoid space. And it looks like, you know, maybe like spider webs or like this really kind of small, very intricate type of webbing. And those connections can also be disrupted through this type of trauma that's happening within the brain, just within the first, again, seconds of injury. And there's also, if you can make this image out down here, within that webbing, there's also sinus drainage, which is important for like eliminating, you know, toxins within the brain or eliminating waste within the brain. And there's also arteries and veins. So all these things are all at risk for disruption. So with that said, I think I just like this video because we put it back in here. It's like, now knowing what you know now, you know, now imagine, you know, this brain shifting around like that, and just how much opportunity there is for there to be trauma in various areas of the brain. All right, so now let's go back outside the brain. You know, this event has happened. The person may or may not already be having changes to the brain that we've just discussed. And now people are on the scene showing up, whether they're bystanders or first responders. There's questions, there's distress, there's uncertainty about what's happening, you know, so emotional distress, which is also a neurochemical change in the brain of increased cortisol levels. And then the first responder's job is to kind of make a decision, like, do we need to get this person to a more emergent setting, like an emergency room, or do we clear them here and then send them back to home, what have you? So some tools that are used out there on the field, the first responders are trained up to understand the Glasgow-Coma scale, which we'll get to that more later, and how that can be helpful, but also how it can also miss the mark. You know, asking questions about loss of consciousness or no loss of consciousness. If we were in a room, I would love to ask people to raise their hands, like how many here would willingly admit they've lost consciousness, whether, you know, you got knocked out, you fell off a bike, you did something. So I'm in the lost consciousness boat myself. So the time that passes is really immeasurable, you know. So if someone, you know, asking me, I couldn't tell you how much time passed. Sometimes people don't even know if they did lose consciousness. So it's very subjective. And if there's no witnesses, it's really hard to make that clear determination. And I choose to emphasize this point now because later on down in the presentation, we'll look at the outcome scales and how sometimes loss of consciousness or no loss of consciousness plays into somebody's prediction on how someone's going to do. And I guess I basically make a critical point here that may or may not be as helpful sometimes when it comes to making outcome decisions. The person's also being assessed for, you know, their arousal levels. Are they awake? Are they alert? Are they kind of drowsy, obtunded, like losing, kind of fading in and out of consciousness? The orientation level questions are pretty common. They use in many settings, asking like who they are, where they are, what's the date and time. They might ask them the situation, like, you know, why are you here? You know, but they try to get some basic orientation information. And if somebody gets all those right, it doesn't necessarily mean that their brain is unaffected. I mean, those actually facts are so frequently remembered and recalled that they're almost automated, and to some extent, functional. For those of us that pay attention to the day every day, we know it. Pupil response time, that's a neurological test that you can do. If you had abnormal pupil dilation, that would indicate there's something severe that's evolving within the brain. But in the case of something mild happening, it wouldn't necessarily show a response. And keeping in mind, this is like pretty immediate early on at time of injury. And then vital signs are always taken: heart rate, blood pressure, oxygen levels, respiratory rates. And because it's an emergency oriented process, there's trauma precautions. Maybe they need to put somebody on a stretcher or stabilize their cervical spine or spine. So now you've got this body being moved around and placed on things. And so it can be quite overwhelming if, we all imagine if we were in that situation. And at the same time,
Jimmy, I know you're getting to some of where these tests kind of break down or are missed later in the presentation, but I think it's important to kind of to set the scene of what that looks like when the trauma ambulance arrives, right? They are often, these things are important. The Glasgow Coma Scale, arousal levels are very, very important when you're assessing what's going on with somebody who has trauma to the brain. But when you're not breathing or you're bleeding, that kind of takes precedence, right? They're addressing some of those issues in a more urgent manner. And so time is passing before you are assessing arousal level or you're assessing, coma scale and these other things. So that skews that assessment because they're looking at things that are more life-threatening and critical. So I know you're going to address that later, but just I'm trying to set that scene for what what it looks like when the ambulance arrives. It's more than just, are they assessing, did they hurt their brain? They're looking for some things that are potentially more critical at that time.
Yeah, absolutely. I'm glad you brought that up because you're right. I mean, it depends on the situation. If someone's bleeding out of their lower leg, or there's all these things that could be the priority. Absolutely. Okay, and so now during transport from the ambulance or the scene to the emergency room, there's communication going on. So that way triage and the ED are receiving some information verbally and some reports from the ambulance. And then at arrival, to Pat's point, that's where decisions are made on what needs to be done first and second and third. So do they have a responsive patient or not? If so, are they a reliable historian? Are they making sense? Can they take information and assume it to be accurate or not? Or if there's a witness there or not that can answer some questions. They do examinations like neurological exams. And then make determination on which kind of imaging might be appropriate. So whether they need x-rays because there may be a potential fractured leg, CT imaging needs to be done of the spine of, again, body part like bones or skull. And we also kind of elaborate a little bit more on this later. MRI also needs to meet certain protocols to be able to prescribe that in the ER, and also the diffuser tensor imagings, and ultimately deciding what to do next. Do we need to admit this patient? Do we need to take him to the surgery room? Do we need to send him home? And so all of these things happening very, very quickly and as comprehensively as that setting permits. But there is a risk for important information going uncaptured because kind of as Pat said, the priorities are the priorities, and sometimes you don't always see the things that are lower down the priority list. And this seems like a good point to stop and just tune into the group since we've covered some of that. Any questions so far?
Yeah, so Jimmy, you guys got a question about imaging, right? And that the question is, what's the gold standard for imaging to show objective brain damage from what you've seen?
Mm-hmm. Yeah, and I'm sure, if those have already done research in the group, you might see various protocols out there that different hospital systems might follow. So the purpose of, let's say, the CT, which is probably the next go-to, if there's neurological deficits from neuro exam, then a CT can give you some quick snapshot within the brain. It can look at fracture of the skull. So that's kind of my long answer to your question. Is like CT is a common go-to, but also knowingly it's not necessarily doesn't give the most clear image. So you might see some dramatic changes. So if there's ventricles, which we got pictures later on down, if the ventricles of the brain are getting, swollen from hydrocephalus, like, increasing fluid in the brain. Like you can detect that on a CT, but it's not a really clear image that's intended to capture little micro or small, type of trauma. It can pick up some like subdural hematomas, typically that are larger, or epidural hematomas. So CT is very common, and MRI would be like the next level if you really want to get clear imaging to determine if something's evolving. So maybe there's a bleed, or they're suspected that there's a bleed, then maybe an MRI would be done next to determine if the bleed is there and if it's continuing to happen.
Sure.
Which then might require surgery.
I'll make kind of a non-clinical observation, but one I saw in the chat, it popped up and it said 3 Tesla. I think that's speaking to the how powerful is the magnet. And that's kind of the gold standard. I think there were 2 parts to that question. One was what type of imaging, MRI or CT, is kind of done urgently, and then the other is what's the gold standard from the actual equipment. And the 3T or 3 Tesla is kind of the standard bearer for the best images. But I'd like to make a comment on it in that that's one of the challenges when folks are working with a brain injury client, is that what you're using those scans in the emergency room for is to figure out, as you mentioned, Jimmy, you're trying to see if you need neurosurgical intervention, right? Is there a bleed? Is there a midline shift? I mean, it's a lot of bad things going on in the brain. They're trying to figure out, do we need a neurosurgeon to come in and put in a shunt, or what do we need to do, right? And so it's very often when, as you kind of talked about earlier, Jimmy, they have a severed artery in the leg, they're addressing that first. They might get to the head and then they do the imaging, but if it's not showing that there's a bleed that needs the surgical intervention, they're going to be looking at a lot of other things. So it gets missed then, or the MRI might say, it is that there's no findings, right? And so when you're trying to piece things together later, it looks like nothing serious was going on. It doesn't mean it wasn't a bad brain injury. It just means that they didn't have a bleed. It might not pick up diffuse axonal injuries and all the other stuff that can definitely affect your ability to function later on. And I know we see that is missed over and over and over just because of what you're trying to address at the trauma unit. So.
Well, and I think somebody chimed in right here, and it seems like a lot of the discussions, especially depending on the topic, right, focuses around diffuse tensor imaging, right? You hear a lot about DTI scans, and one of the questions that just popped in, Jimmy, was about the efficacy of NeuroQuant, right, that they use with a lot of the diffuse tensor imaging that comes in. Didn't know if you had an opinion on it, or if it even comes into consideration when you're talking about the post-acute settings, right?
Mm-hmm. And that's asking input about DTIs for the efficacy?
They're asking about the NeuroQuant program, neuroquantitative analysis, that's usually accompanying diffuse tensor imaging, or the DTI scans that are done.
Mm-hmm. I'll probably just say what's in my scope of knowledge, because I'm not as familiar with the NeuroQuant analysis you're talking about.
Okay.
So but DTI, I guess, going to the post-acute side, I would say across the past 20 years of practice, it's become more and more recognized. But there's also like education out there within the physicians themselves, neurologists, deciding if that's a tool that they want to use and when to use it. And Pat, maybe, I don't know, maybe you could elaborate on that better.
Yeah, I'll address that, because I find DTI very interesting, because my background has been in working with acute rehabs, post-acute rehabs all across the country. And so DTI is not generally, at least not yet, used for differential diagnosis. So they're used after the fact. They're not, if you're clearly in an ER setting, that's not what you do. And even in an acute hospital, on a rehab, those managing physicians won't order a DTI for evaluative purposes. They're not looking for a differential diagnosis, and it doesn't affect their treatment. So DTI is used later down the road when there is damage that has occurred to the brain, and then there are changes to the brain over time. So they're done generally later, 6 months, 9 months. There's arguments on different lengths of time, but they're done later, and they're a very good tool to show something that you have a definitive picture, and it shows sort of a decrease in function, if you will. And it's most beneficial if you do neuroquant, because that gives you more than just saying, this is what's going on with the brain. You then are saying, and this is how it compares with a database of like individuals, so you can see this is what it should look like, and then this is down the road what the actual patient that you're talking about, how their scan looks. So I think that it is very important that that is used in conjunction with a DTI. It's not a scan to be used alone. So I think it is important to look for a good solid database to measure against. So, and then I think it's an effective tool when used properly. And again, I'm not a clinician. I've just seen a lot of folks using them and working with them, and that's all the feedback that I get. Is it is a great tool, but it needs to be used in the right timing and in the right setting and for the right purpose.
Yeah. Okay. Great. I think before, since we stopped right here, I think before we went any further, Ginger wanted to bring in a couple of our sponsors. So Jimmy, if you want to close out of your show, and you can pick right back up once we meet some of our sponsors. I see my good friend Cody.
Oh, there he is.
No, I'm so happy. And I tell you, you guys, I just have to do a quick little, I guess, mention that we're going to be doing our Nashville TBI seminar, which is coming up May 5th through the 7th. However, we also added an additional event on May 4th, where we are actually booking the whole Country Music Hall of Fame. We're doing a special event with Max Barnes, who's like a famous songwriter. We're going to do a meet and greet. It's like a lot of fun. But Kyle's going to be there speaking. Cody's going to be there speaking, and we're going to have so much fun. Pat, you guys, you got to come. We're going to have a good time.
Sounds
But
great.
Cody and I have been working on some secret projects together.
Oh no.
Top secret.
So I can't help but smile when I see him, because we are going to have a lot of cool things happening there. So Cody, your team is amazing. I'm always impressed with everything that you guys do. And John Romano, again, he raves about the work that you guys do as well. We're so happy to have you back with us today to share some of the things that you guys do. And I'm hoping you're going to show us a video or two.
Yeah. So believe it or not, we do brain injury stuff. We do TBI graphics, and yeah, we do a lot of that. It's actually kind of our bread and butter. So I just kind of wanted to show you a little bit of some mechanism of injury animations that we've done. And this is a great way to like explain coup contra coup and the gelatinous nature of the brain. So here you've got a front end impact, head hits the steering wheel or even the airbag, and skull impacts coup, the front, and then contra coup, the back, without even hitting or making contact with a hard surface. And so after you explain contra coup, you can start showing images. And this person got hit by a walker in the head. Ouch. Here's a rear end collision. So coup, and then whips back, and the seat belt actually grabs the chest, and the front of the brain actually makes no contact except with the skull. I'm sorry, the front of the head makes no contact. It's just the front of the brain with the skull, and that would be the contra coup. So contra coup can happen in the front or the back. It just depends on where the initial impact was. And so Dr. Moody was talking about, CTs and MRIs. We do a lot of DTI imaging. So there's your normal brain. And what I like about these is there's a CT image. It gives you a context of like what that is. That's an axial CT, and not actual, but axial, right? It's top down. Actually, it's actually bottom up is a better way of putting it. And so you get contusions, and a lot of times they'll say, hey, that's not permanent. Oh, but with the MRI or the high contrast, or different, a lot of different things that Dr. Moody knows about, and Pat knows about. You can see 2 years later, guess what? It's chronic. Bad news. You didn't believe that one? Oh, here's another one. Initial scan. Contusion. Is it permanent? Defense always says, no, no way, man. It's not permanent. Oh, let's see if it's permanent or not. Well, when you look at another scan 2 years later, you see not only that, but also some microhemorrhaging. Maybe I'm not on this one. Oh, yeah. So little microhemorrhaging and chronic contusions. So it's a way that you can show, permanency and things of that nature. And yeah, so we have a lot of fun with what we do, working with great doctors. And so thank you for this webinar, Pat. And thank you for this webinar, Dr. Moody. And again, Kyle. Oh, always good to see you, man. Kyle's the star of the show, Ginger.
Cody, thank you so much. We love having you. And don't forget to put your information in the chat box. That way everybody can stay in touch and give you a call. So thank you.
Awesome.
Thanks,
Hey,
buddy.
thanks, everybody.
All right, we'll see you soon. And now I am so excited, you guys, because we have Taylor joining us today to share a little bit more about what HMR does. We're excited to have Taylor with us. And especially if you're new to watching their webinars today, you're going to learn a little bit more about all the great things that they do over there. So Taylor, thank you for popping in. We appreciate it.
Thank you as always, Ginger. And it's always tough to go right after Cody because, y'all just get me and talking. I don't have any animations, cool graphics you can see, but I can definitely tell you we can fund everything that Cody can do. But again, my name is Taylor Luce. I'm the Southeastern Regional Manager for HMR. I cover the Carolinas, Tennessee, and Louisiana. And obviously, a lot of you guys know we can do the medical funding for these cases, from your most basic single study MRI to this DTI or to a catastrophic, TBI. We can fund it. But, we've all added a few, programs that we think can help, the case from start to finish outside of the medical funding. These guys come to the law firm or they need loan to help pay for rent or car payments or mortgage or groceries for the week. And, we can help fund that as well. And, it's less of a strain on the law firm. And then to bundle it all up, make it nice and tidy at the end. If you need an accident reconstruction or a life care plan, or Cody's, expertise at Fox-AE to get these animations, or get an expert to come testify live at trial, those costs add up, and we're here and we want to be able to facilitate those costs for you, whether it's the medical funding, pre-settlement advances, or our expert funding. We offer all three under one roof. We're operating in all 50 states. And we do a lot of work with Pat and Dr. Moody at NRC. We do think if y'all give us the opportunity to work on one of your cases, whether it's an MRI to a TBI, we do honestly think we can change the trajectory of the case. And thanks again, Ginger. It's great seeing Pat, Dr. Moody, and of course, Kyle. Happy to do this and look forward to seeing y'all again soon.
Absolutely. Taylor, thank you so much for joining us. And you guys cannot say enough great things again about Taylor, his team at HMR. You guys are amazing to work with. And I know we are very lucky to work with you on a daily basis. So please come back anytime and be sure to put your information in the chat box. And then I did have a question just come in, Taylor. Do you guys also operate in Texas?
Yes, absolutely. I was just about to respond to Mr. Maddox there.
Okay, fantastic. All right. Well, thank you so much. We'll see you back here again soon, and have a great afternoon and a happy leap day.
Thank you, Ginger. Appreciate you guys.
Absolutely. All right, Kyle, I'm going to hand it back over to you.
All right, fantastic. Okay, well, I want to go ahead and dive right back into it because I know, Jimmy, you've got a ton of information to share, and I know we're kind of setting the stage, right, for kind of leading into the post-acute setting. So I'll turn it back over to you, and you can get going.
All right, great. Okay, that was good. Yeah, I appreciate Cody and Taylor. Also along the way, like if questions come up and we don't know the answer, I don't know the answer, I'm making note. Because at the end of this, we're going to give you guys some information on how to get a hold of us, or at least get through Pat. We can always do some follow-up afterwards. But yeah, for the sake of time, I mean, this has gone by fast. I think Ginger said this was going to be like super fun and furious, and it is. So now I'm thinking how to kind of get through this quickly, but also not shortchange the group with information. So let's jump back into the brain, and I'm going to start sharing my screen again. All right, Pat, can you see the slides?
Yes.
Okay, awesome. Oop. Okay, there we go. Got it.
No, you're good.
All right. Okay. So back to the brain. We went through the anatomy, and Cody, that visual was awesome. I wish I could have snuck that into this presentation. It makes it so much more relatable when people can see like what happens. So we'll spend a little bit of time here, and maybe the next 10 minutes just focusing on brain anatomy. I'll try not to be too nerdy with it, but if you're into it, I think it's sexy. So the different lobes, and when, like, going back to Cody's visualization of, when you see trauma to the front or to the back, like in this coup contra coup, there can have not just the physical damage that you might pick up on an image, but also a clinical presentation. And then that's really like the next theme of these slides is how will this present in a person, right? If now they have injury, because sure, there could be something that demonstrates trauma to the actual anatomical area of the brain. And, I imagine 20 years from now, there'll be something that exists that's even more clear that can demonstrate these things. And at the same time, in parallel, you've got a clinical presentation. What is forgetfulness? Like, where's that in the brain? Or distractibility, where's that in the brain? So that's kind of the intent behind these next slides. And there's some information that you'll be able to get on the slide deck, but also I encourage notes, because we'll probably improvise a little bit of extra info. So frontal lobe really is, it is like the main center of the brain as far as, it's the command center of our personality. Your personality and the way you are, without being philosophical here, is basically housed in your frontal lobe. And sure, you have, your own motivations, your own drive, and your past experience, and all those things that go into like who you are and how you were made to be the person you are today. That has an actual home within the brain, which is the frontal lobe. It's your personality. So after injury, you can see changes in personalities. Jimmy's the nice guy, now all of a sudden he's a jerk. Like, why did that shift? Okay, that didn't make sense. Possibly there was, again, injury to frontal lobe. Self-regulation, being aware of how I'm behaving in a social group. Am I like speaking out of turn? Am I interrupting people? Being aware of deficits, so self-awareness. Am I regulating myself properly, improperly? Also a lot of organization and planning. Like, if I'm going to go to work today, what are the steps that I need to do to sequence, to get ready, to put my suitcase in the car, to grab my car keys, and so on and so forth, and meet my first appointment on time. And all these things really are functioning and on fire in the frontal lobe for hitting all those things, for performing in that way. And also attention and working memory. You'll see in different slides here that your attention and your memory actually exist in many places. And I'll kind of explain why here in a minute, but the frontal lobe does have a specific area of the brain, the prefrontal cortex, that's thought to be the most, it supersedes, attention. So if you're focusing on something, that's part of frontal lobe. But for you to not get distracted by something else, that's also a more a higher level of function of the frontal lobe as well. So that's housed there. And then also the motor cortex, the prefrontal motor cortex, the supplementary motor area, these big sections of the frontal lobe that actually are responsible for, the left side of my brain will tell the right side, my right side, what to do. And vice versa. Right side of my brain tells the left side what to do. And
Jimmy, I think one of the critical things in this slide is not just what the frontal lobe does, but that final word in the title of function. Okay, I know that it's real often everybody's looking for very mechanical, very clear evidence that there is brain injury. Well, now there are types of scans. There's different things that you can do, but the having an expert who evaluates and assesses what's going on in these issues and regarding personality, self-regulation, organization, all the things that the function of the brain when there's damage, right? It could be, again, diffuse axonal stuff. It could be degeneration. There's a lot of things that happen after an accident that this is just as critical, in my opinion, when it's observed by professionals who know and understand what brain injury looks like and how behaviors and attention and those kinds of things are very, very clear cut and follow a fairly distinct pattern by that can be observed by clinicians who know and understand that. And so documenting what's actually going on in their lives and the deficits and the things that they're struggling with are also critical in understanding how a brain injury is affecting their lives, and not just we can see it on the scan. Now, people like Cody can take, you know, these things in an image and make it understandable to people because they're very clear, they're very, you know, definitive in what they're showing, and that's very, very helpful. On the other side of that is the behavioral side, and how does it actually affect your life? Because that's where lifelong things happen too. When you can't remember or don't have the attention or don't have the self-awareness anymore, that can affect the rest of your life, regardless how old you are. And so those are critical.
Mhm.
I think that function component is critical, and it's not only a scan or a surgery or something that's hard and easy to understand. This is a key component as well. And professionals like yourself who treat these kinds of things, you know, I think it's overlooked its importance very, very often.
Mm-hmm. Yeah, I think that's well said, Pat. I like to make this point, not because it has to do with brain injury, but it kind of makes the point you're making, which is, you know, for example, in Parkinson's disease, that's a clinical diagnosis, meaning you're not going to find an image or a test that's going to show that person has Parkinson's. It's a clinical diagnosis, meaning there's experts that have to do types of testing and assessing and observations and assessment, very similar, like to what you're saying. It's the proof is in the pudding. You assess it, you assess their function, and then you start treating it. So moving us along, so occipital lobe, the back part of the brain, and its function is vision. So sometimes after, again, some head injury, maybe a concussion, you might have some visual changes, indicating possibly something's going on in the back part of the brain, the occipital lobe. So acuity is, you know, can you see the E on the chart? You know, like you got 20/20 vision, you know, binocular vision. Are you getting blurred vision? Are you getting diplopia, where you have kind of double vision? That's part of occipital lobe function. And then visual perception. So as you kind of view the world and you're stepping out of your house, you know, how far are the bushes? Is there a step in front of you? What's the color of the sky? You know, and then cars passing by, like all these things are happening very automatically in your brain processing that you may not even think about, but they're all processing to give you a reality that you're about to interact with. So again, just another equally important part of the brain that gives you an idea of what the world looks like around you. And we're going back to the memory point, is a visual memory. So if you want to, you can play along and close your eyes and just take a few seconds and just visualize your childhood home. It doesn't matter where you're looking, if you're in your bedroom, if you're in the backyard, whatever, but just you being able to pull that visual memory back up of what that looked like, that's housed in your occipital lobe. And that was 20 years ago, 30 years ago, 50 years ago. I mean, it's time has passed and you can still hold that. And that's just, you know, an example of an impressive piece of what our brain is capable of. Parietal lobe, this sits in between the occipital lobe and the frontal lobe. And its primary responsibility is sensation of touch. So like earlier I said, movement, the left side of my brain is responsible for the right side of my body's movement. That's information going out. When there's information coming up, so if you touch your right hand, the left part of my brain is actually going to process that you touched the right side of my hand. So that's processing center for touch, pain, movement. You know, so if your arm's moving in space, it has this sense of where it's moving because of that information that's getting processed in the parietal lobe. So it's more of a processing center. Also just how you're sitting or standing or lying down. If you're uncomfortable, like that signals up in the parietal lobe. Going back to memory, example of sensory memory. Again, if you care to play along, close your eyes. Now try to imagine as if an ice cube or a pinpoint, was touching your left hand. Now we can't do this right now, but guaranteed, if there's a functional MRI going on with you right now, you would see your sensory cortex start to light up because your brain processes in that way. So even just you visualizing or trying to sense that this is happening, your brain is going to start to try to process it just through imagination. And moving to temporal lobe. So this is on the side of your head, kind of where your ear is at. So to no surprise, it's processing center for hearing because it's anatomically close to the ear. It's also important for language, probably the most important part of the brain for language and understanding. You're processing my words and how I'm saying things because this area, Wernicke's area, is in the temporal lobe, and you can process that information. But also, if you're going to give a response back, you also got to compute and create the words and the sentences that you're going to say. That also occurs in the same area. So you can have deficits in one, you can have deficits in both, based on, again, the area that was injured. Same thing with memory. If I'd ask you to recall the first name of the name of your first grade teacher, maybe you remember that, maybe you don't. Maybe you're going to remember it at dinner tonight and it's going to finally click back to you. But this is housed in the temporal lobe. And it's more of a long-term memory storage area, if you will. And cerebellum is back, really kind of in the back part of your skull, like probably at the bottom of your hairline. And the cerebellum, for those interested, it's called the neocortex. So it's actually, as we human mammals evolved, this is the newest part of the brain evolution. At one point cited to be probably around the time that we started consuming meats. And so the brain started expanding and our motor skills started to evolve to where we had to be hunters. And so this function of this part of the brain is coordination, muscle movements, fine motor movements, balance and equilibrium. So its function really is around coordinating our body movements. Like as we move to simply pick up, a glass of water or to do something complex, in sports or climbing a mountain or avoiding, collision out on the sidewalks when you're walking around, all these different types of maneuvers are really kind of coming from this control center in the cerebellum in the back of your head. And it sits just below the occipital lobe, but there's actually a bone that kind of separates those two together, and it's housed in its own little bony space. And muscle memory, like a common term we use, just you can remember how to shoot a free throw or ride a bike or these things you've practiced through repetition. So your cerebellum has a memory function to it because it can remember how to do these things through practice and repetition, and you can get better at it and you get worse at it. But this is where that occurs in the cerebellum. And then we got the brainstem. And this is actually really important. And I wish I could convey this better, like in person, but you got the brain that's surrounding it. Like we said, the cerebrum, which is the big part of the brain. And then you've got the cerebellum there, but right in the center of that is like kind of the stalk, it looks like kind of like just a stalk of a vegetable. And why that's important is because it's sitting in the middle, kind of like straight up and down, and everything else around it is actually going forward and back. So imagine those forces inside the brain through this trauma. That stalk, the brainstem, is not taking the forces in the same way that the other part of the brain is because it's on a different vertical line. And then you can end up with these torsional effects. And why that's important is because trauma can happen in the brainstem, even though that's not the first, sign of injury, maybe, because all these little micro traumas are happening within it. And the brainstem is quite literally the most important part of the brain because it's what keeps us alive. It has these critical life functions. So it regulates our pulse, our blood pressure, your breathing, you're speeding up breath, slowing down. It affects our sleep-wake cycle. It also has nerves that go from the nose to it to process smell, from your tongue to your brain, to brainstem, so you can process taste. And it controls your eye movement. So a lot of it is our vital functions. And when this area gets damaged, even if it's micro level, you can see things like maybe somebody has affected their sleep, their taste and smell, or their sleep-wake cycle is off, or they don't have this regulation of their vital signs. Heart rate might run higher, blood pressure might go up and down spontaneously. Eye dysfunction and control. And then the vestibular system is an inner ear piece, but it actually goes and feeds over to the brainstem, which will give you a sense of where are you standing up straight, are you leaning left. People that get dizziness, this is also that part of the brain.
Jimmy, I'm gonna jump in for just a sec. I think I know we got a ton of information, so
yeah,
I think that for the group who's listening, I think one of the most unique things, and certainly your area where you spend a good chunk of your career, is at the post-acute rehabilitation level. And so I think it's kind of a unique kind of program. And so I think that would be something, if we can maybe move through to that section to talk about it, because post-acute, residential, community reentry, however you want to phrase it, or whatever you want to say it is called, it's that phase after they've been to the ER, to an acute hospital, perhaps a rehab unit, and they're kind of ready to go home, but they're not really ready to live life anymore, right? They've got memory issues, they've got agitation, they've got all the things that are all the stuff that you described in the brain, the functionality and the problems that are created from the brain injury that are manifested in behaviors, memory, all the things, executive function, that's addressed at the post-acute level, how they live their life, right? And they're documenting during that phase with PT, OT, speech, a physician, nursing, all the things that are going on in their realistic life that are challenges to them that could be lifelong, or at least need to be addressed therapeutically. So I know you have a lot of slides that will explain things, but I think we might want to move kind of towards that for the sake of time, so that we can definitely get into your level of expertise as far as treatment, and people can get and know and understand how that's used to treat and diagnose and kind of support the rehabilitation of individuals who've had the brain injuries that you have described with your slides so far, right? And how do we behaviorally and how do we support them and get them to move back to a regular life as they can. So maybe think through where you are in your slide deck and maybe click to there and address it. And if people want us to go back to some of these things, we certainly could, but I just don't want to miss your sweet spot of exactly where you help people.
Yes. Okay. Thanks for that. Yeah. So we're going to go 100 miles an hour real quick, but I just want to pick on the severity rating scale and then get to community reintegration, because, I imagine a lot of the audience sees this stuff, Glasgow comas, loss of consciousness, things like that. And the reason I choose to pick on it is because it's becoming a little bit more widely criticized. There's an article that's recently published in 2021 that, these experts, including Nathan Zasler, one of the leaders in brain injury medicine, basically says that the TBI community should stop using severity labels, which may cause more confusion than clarity for patients, families, and the society. For example, like a mild TBI doesn't mean that the deficits and their impairments have a mild or less significant impact on a person. And, we talked about so much of this stuff earlier on that I want to get past that real quick, but pretty much you have these measures that were created 3, 4, 5 decades ago that thought were to be useful. And now current day, they're turning out to be as less helpful, and in fact, creating some confusion. So if I sustained a mild TBI, AKA concussion, then somebody might wrongfully misinterpret that as, oh, well, that just means my injury was mild and it's not as significant, or how it's affecting my life is less significant than others. And that's not true, and that's not proving to be true. And these slides are all here. We're going to share them with the group after the presentation, so you can go back and reference kind of how the Glasgow coma looks, or to go to these imaging we already talked about. And the clinical presentation can probably blur in with community reintegration. So I'm going to bypass the slides, but know that there's stuff in here that says this is what the symptoms might look like, and then getting to expertise of what we do about it. And I thought that it could be helpful that people know how to interact with somebody that has had a brain injury. You know, they might be distracted. They might not be able to tolerate paying attention for longer than 2 minutes at a time. So I kind of work in some tips as we go. So Pat, you know, like you're saying with community reintegration, you know, and post-acute brain injury, you know, our expertise is rehabilitating the brain, its function. So yes, it's had some trauma. Yes, there's been some anatomical changes, but for the most part, somebody might be considered stable, but functionally, they're not necessarily stable. They need to learn or relearn how to use their attention, how to use their memory, how to use their decision-making and judgment. And it might be, you know, might be impaired, you know, so and working with cognitive rehab can be challenging to explain and challenging to treat, because if I lost my leg, you know, today, you're not going to ask me to walk tomorrow because I don't have a leg. But if I lost some type of attentional part of my brain, you would still expect me to pay attention. And that's the misstep that people can often make. They don't see it, so they don't think of it in that way. So here for us in the continuum of care, we've gone down the road, emergency room, intensive care, neuro ICU. The patient is alive, they're stabilized. They go into some type of potentially rehabilitation setting, like a hospital rehab. And then from there, they need services that are more specific and specialized and potentially take longer, you know, because again, I've kind of ranted about how impressive the brain is. So to me, it's not a surprise to say, well, it takes a long time to rehabilitate that as well, because it's complex. You know, it's not a bone that has to heal in 4 weeks when you put a cast on it. You know, the brain is constantly needing to be trained and tested, and also allowed opportunity to rest as well. And the post-acute space allows us to do that. So we might serve people, you know, months after injury, but sometimes years after injury, because there's still uncovered recovery, or somebody has not adapted well, and they need an expert to show up on the scene to help them understand what their deficit is about and what they can do about it.
Right. I'll jump in on this component. It also kind of ties into the article, and I know we can make that available to anybody who wants it, because I know, Jimmy, when you and I were talking a bit about residential or transitional rehabilitation, kind of to set the table for those who are listening, you may or may not know what that setting is, right? You had a graphic, Jimmy, that showed all the different phases of care and how you get there, and that is great. But once you get there, people may not understand it because it's a very unique setting that a lot of states don't even have a program that have a post-acute brain injury rehab. They might have an acute rehab hospital. They may have, you know, acute hospital setting, but they may not have that. There's a lot of states that don't even have it, but it is a very specific type of facility. They're licensed differently in a lot of different states, but the function is generally the same, and that is supporting in a realistic home-like setting someone with a brain injury to help them get back to the tasks that they would need to do to be independent at home. And that's done with physical therapy, occupational therapy, speech therapy, nursing, all of those disciplines in a very realistic home-like setting, so that they have a more durable outcome because it was performed in a real setting, a very home-like setting. And it's documenting everything every day that they're struggling with. When they left the oven on, or if they walked outside and weren't aware of you know, there's traffic, or they take them out into the community and they get, you know, agitated when they're at Target, or all of those different things. So the article that you referenced, I think is important if people want to see that, because I know you and I had a discussion about the fact that although you can take a patient who has insurance, you know, Blue Cross Blue Shield or whatever, you can take a patient who has a workers' comp. There are a lot of patients who don't have health insurance, or it's inadequate, and that's where funding companies, you know, help that patient, because they help them get access to this level of care that puts them back on the right path. So there's a lot of pieces, and that's where you and I kind of have to work together when there are, I coordinate, and find resources for individuals who have brain injury. So I can help with DTI or evaluations and getting them to post-acutes. And so all of those things together, I don't know that everybody understands what this level of care is. So really kind of drilling down for the remainder of our time and then taking questions, I think would be very beneficial for them to understand how this, as far as documenting what's going on with the patient, is just hypercritical for the long-term understanding of their issues.
Got it. Okay, cool. Yeah, so just to set that, you can imagine like people going through this recovery process, they're usually in some type of very structured setting, like a hospital, and there's call bells and there's multiple physicians and all that. So it's really not natural world for them. So for our setting, post-acute brain injury settings, residential settings are set up in home-like settings. So it has a regular kitchen, for example. Even though maybe it's ADA, it's not set up like a hospital. So the environment is set up more of like the real world experience, which is it's important because there's something known as, specificity of training. So when you're training somebody, the more specific environment you train them in, the more specific demand and task they learn, the more likely they are to be able to learn it and then sustain it. So you want to be in a home setting. We also go out into the community. So we might do outings to the grocery store, for which again, tasks different cognitive abilities on identifying what ingredients you're going to need for your meal, how much is it going to cost, how long will it take me to go there, how am I going to commute there, so there's all these things that go into a community outing, even to the grocery store. And they can get more complex, to being, travel. You have to get on an airplane, or you have to, go to a, baseball stadium and have it to navigate lots of people and stairs and all these things and cross streets. So your care is provided inside of a home-like setting, but the community is also the rehabilitation setting too. So we get to go out regularly to test the skills. Like, did I learn what I need to do to pay attention when I go to a restaurant and read the menu and give my order when my name is called? It's really true real life application. And so, here, you're rehabilitating, the physical person, but like we've talked about, the cognitive person, and then also the psychosocial element. As some could imagine, losing some mental abilities, cognitive abilities, physical abilities can also cause somebody to feel distress. Like maybe I won't be able to be the spouse I want to be, or the parent I want to be, or the worker that I need to get back to doing so I can have an income, or all these things that are distressing. And some people have family support or friend support, and some people don't, or they have more, or they have less. And that psychosocial part of the recovery process is equal in this whole recovery process.
Or their support drops out over time, right? Friends come and visit over time, but then once the patient sort of healed, or they're back at home and they realize they're not the same person, they don't have the same interests, or can't keep up the conversation the way they used to. Those are the things where they begin to get isolated and lose contact with, at least with friends, and sometimes even with family. Yeah, very true. And that's so a sense of loss, and this is anecdotal, but I would say I've seen this over and over and over again, that the friends are the first to go, and then even certain family members start falling off, and it's usually like a mom that sticks around. It starts that circle of family and friends, it starts to narrow and it becomes a very isolated and potentially, lonesome experience. Right. So that, to make the point, like all this goes together just as equally as important. And yes, sir.
Before you hit that slide, I know Ginger had given me a heads up that we had one more sponsor that we were going to hear from, and then we'll jump right back into the program. Okay.
Got it.
Absolutely. And you guys, I am loving all of this. I know that we're going to be breaking this out now into a part 2 session, which I'm really excited about, because then I get to have all of you guys back with us. But there is so much awesome information to cover. But we have Patrick with us. I wanted to introduce you to him real fast. Amazing Oh my gosh, Patrick, I think you've been a nurse for 30 some years. How long?
Oh God, no, 19.
Okay, well, I was close. You're getting there. But still, I tell you, it's amazing all the information that you know as well. You guys know that John Romano, he raves about the pain and suffering reports that you guys do over at OnPoint. He uses you guys in a lot of his cases. So we're just so lucky to work with you. And I'm hoping that you can run through some of the other things that you guys offer as well. But we're glad to have you with us today, Patrick.
Of course, thank you, and nice to see you again. I won't hold it against you that you thought I'm 30 years older than I am, but my name is Patrick Stoneridge. I'm one of the nurses and one of the program directors over at OnPoint Legal Nurse Consulting and Expert Witness. Fascinating. Thank you very much. You've taught me a lot. I am not a neuro nurse. My background was in cardiac ICU, and then I went into the crazy world of community health, of home health and hospice and long-term care. So we see a lot of the TBI patients when they come back into the community, whether they're coming into their private homes or whether they're going into assisted living facilities, skilled nursing facilities. And I've been tasked with way too many times of violence in skilled nursing facilities and group homes that cause traumatic brain injuries. We still see that a lot. I review many cases with my expertise. But the biggest thing that I think is helpful for this topic, like Ginger said, is the pain and suffering reports, and of course, life care plans. I'm one of the individuals over here that does the pain and suffering. One of the interesting things, and I know John Romano raves about him, is it really tells a different perspective and story of what happened to the patient and what happened, that everything past that injury. So how they were functioning before, then we have the injury, and then we have everything that happened afterwards and how that's affected them. I did a pain and suffering report for a motor vehicle accident a couple weeks ago, and I went through the whole entire process of every single invasive procedure that was done besides just the injury, and how it hurt the patient and how that is affecting their life. As simple as a Foley catheter, to an intubation, to an extubation, to any of the procedures, and kind of how that's changed things, how it's changed their family, how it's changed their sex life, how it's changed their work life, how they just feel on a daily basis. They're lengthy reports to put together. I think they're very beneficial, just because it gives a different perspective besides just the medical side. We also do a lot of merit screens for our attorney friends, which is in the very beginning at intake. If we can help kind of screen the cases before it gets too far to where there might not be a strong case, and we should all kind of run in opposite directions, or they can, shop around if they want to find someone else to support their case. I would do medical chronology, so putting everything in order with hyperlinks back through the source document to make sure everything kind of stays organized. We can update those as we get more and more records coming in. Like I said, we do have a certified life care planner on staff. Her name is Lisa. Dawn helps with all of our medical experts, and myself and Ingrid, we're the ones that are in charge of all the long-term care experts and nurses and medical providers to assist you guys. Rachel's in charge of our record retrieval. So any records that are out there that need to be retrieved and come in for review, Rachel's in charge of all of that. So it's a wonderful group. I've always loved being on with Connectionology. You guys, HMR, you guys support us nonstop. Cody, you're always fantastic to us. So I truly appreciate it. And hopefully we'll see you guys. I'm speaking in Nashville about pain and suffering reports. So hopefully I'll see you all there.
Thanks, Patrick.
You're welcome.
All right. Jimmy, we're going to let you get right back into it. It's I know you're hitting on the community reintegration part and kind of what it's all about. And so, Patrick coming in with life care plans is kind of an appropriate point. I had somebody that we do a fair amount of work with, and he would often say, with a lot of these brain injury cases, you have life care plans where they're talking about what they're going to need for the rest of their life and all of the future care, especially as it relates to neurocognitive rehab. And a lot of times he's saying they get forced into that moment where but how do you prove up those life care plans, right? And that's through some of the rehab and the things that you're providing. So I love that you're kind of getting into this because it goes hand in hand with what Patrick was just talking about. So
Yeah, I agree. I think that's perfect segue.
Awesome.
Yeah, so
Well
Patrick's
done, Patrick.
Exactly.
Thank you again so much for being here with us today, Patrick.
You're
And
very
please put your information in the chat box as well. And you
Will do.
guys, Patrick is also one of our speakers in Nashville coming up in May as well. So I just can't wait for all of you to meet these amazing people in person. So it's going to be a great time. Thank you for being with us today, Patrick.
Of course. Talk to you soon.
All right, Pat, Jimmy, and Kyle, back to you guys.
All right, thanks so much.
All
All
right.
right, Jimmy, all yours, bro.
All right, thank you, sir. Yeah, so Patrick sees that and writes it. And so on the service side, we're the takeaway is that post-acute, we're able to provide services inside a home-like setting, but also in the community. And that's really where the rubber hits the road. So as much as you can imagine that we might do that's specific to a person, like their own interests and their own pre-morbid roles, if they were a parent, if they were a worker, if they were a volunteer with their spiritual groups, I mean, all those things we can specify and get our training hand over hand with those people in those situations. And so to be able to do that is such a rare opportunity, but it's such a rare service. And like Pat said earlier, it's not like they're all over the country. They're not, multiple in each city, so we're very niche and we're very specialized. So the skills that we teach and train our staff are also very specialized. So if somebody needs to learn how to do their laundry before they can learn how to cook a hot meal, then that's the order it goes in. But we're able to be there to supervise and oversee, to prompt them accordingly, but also allow them some of their own time and room to figure some stuff out on their own, to include making mistakes, because that happens, and there's a lot of lessons that occur in that. So the task specific skill training is exactly that. We train specific to the skill that they need to learn how to do again. If their muscles are weak, then we do strengthening. If their muscles are tight, we do flexibility. So all of that still happens. But if they really need to relearn how to do something, then we can do exactly that, person by person. We mentioned earlier how to be able to safely get out into the community again. It's not uncommon that somebody that's had a brain injury can't drive right away. So what options are out there, especially if some of these transport services cost money? What options do they have to get out there, so they can reintegrate into the community?
Jimmy, you want to jump to full screen again? I'm sorry, you're in display mode. Sorry.
Yeah, I'm glad you said that. Current slide. Here we go. Okay. Yeah. So like getting back to that's better. Okay. So
yeah.
So back to their own interest, going out to movies, but also socializing. And just spend a couple minutes on this is, social skills and social interaction, it is a skill. So, I mean, we all know those people that are very pleasant to get along with that may or may not have had a brain injury. And then we also know those people that may not be that pleasant to get along with, and they may or may not have had a brain injury. So, but to be aware of how you present yourself in front of others, how you interact with others, that's proving to be one of the most important or critical functions for successful reintegration back to life roles. If somebody can be socially appropriate with others, then they're more likely to regain a friend, regain a family member, and then that turns into 2 to 3 to 4 and so on. But then the opposite is true. If somebody can't master their own social skills and they're unsuccessful, then those friends start to go down and down and down. And unfortunately, again, it's just more of like an isolated life experience, which is loss and lonesomeness. So social skills is really well trained, yes, in one-on-one, where let's say myself and a patient were, having conversation, and I would ask them, have you ever noticed that you interrupt, like build awareness around it and then have a conversation? What can you do to not do that? Or how can we take better together? And all these things are things that we can train. But then also in groups. And so where those are like real life situations. So we have groups in our settings where clients will interact, they'll prepare a meal together, or they'll go on an outing together. And there's nothing more impactful than when one of your peers, in your recovery group can just call you out on your shit and say, like, don't do that. Like you're being rude to me now, or, because like we as our, clinician hat on, they're accustomed to us, having this relationship. But when your peers are trying to give you that feedback, it seems to make a much more lasting impact. So groups have these pro-social behaviors. They have to be interdependent on one another. They have to rely on one another. And it promotes natural communication. It promotes you got to actively listen to others, try to be open and receptive to somebody else's perspective. They can also practice their own assertive communication, and also getting frustrated, because when you got that person in the group that's just pushing on everyone's nerves, you're now experiencing your own frustration and what you do to tolerate that internally. Very natural world thing. And also exposure to natural stress and social pressure, like if you want to do something or don't want to do something within a group. And also equally, sharing these achievements. So when you have successes and you succeed with other people, you have a sense of camaraderie and accomplishment and dopamine dumps and, really, really good positive feelings about interacting with others, which then sets them up to be more likely to succeed when they socialize with the people in their real lives. And that's also a big part of our programming that we have in the post-acute rehab setting. We made mention of natural consequences, like letting mistakes happen. And I know about everyone in the group, but I have certainly learned lots of lessons through mistakes. And this is true for people with brain injury too. So permitting a safe amount of error to happen, meaning don't let them touch a hot stove. You're going to let them learn the hard way that way. But if they're not going to cause harm to self or others, then we allow a certain amount of space for there to be errors or mistakes. And then you pause and go, oh, why did that? Pasta turned out overcooked. And you turn it back into like a retrospective learning opportunity. And then the next time around, you correct, and lesson is learned.
And I think, Jimmy, for everyone to understand as well, from a therapeutic standpoint, that makes sense, because you can tell them, hey, you're going to burn the toast or you're going to overcook the pasta. But until they see and smell the burnt toast or have to eat, taste pasta that is turned to mush, that's when it really is more impactful to them making changes in that behavior and kind of remembering those things. So therapeutically that makes sense, but also, since there are professionals in the building, again, PT, OT, speech, that do specifically brain injury, it also is important that they're documenting burnt the toast, didn't understand, forgot the timer, because those can be either things that are impacting their life, or can be something that is dangerous in their life. Like, you leave the oven on in a post-acute facility, there are, tons of professionals around to pull you back when it gets to a dangerous point, right? But at home, that could be something if they're trying to live independently or their support system has to go to work. Those are things that can present, a danger to their lives. And so those things being documented in their everyday realistic life, I think are critical and key to understanding those issues that they're struggling with. So I'm sorry.
That's perfect, Pat. Yeah, absolutely. And actually, probably that's where it's a good place for us to end. If this is our ending spot, is that in our settings, it's always goal centered. It needs to be patient centered or client centered, so we understand what is it they want to achieve again. And if we know that and understand that, then they're more motivated to pursue those things. If someone didn't want to be a basketball player and we put that on them, then they're going to be motivated to learn this stuff. So, we always focus on the goals of the person and ask them questions like, what do you want to be able to do again? We ask the family, what would you like them to be able to do again? Can you leave them unsupervised for 4 hours to go to the grocery store? What do you need to see happen for them to be able to successfully reintegrate back to home? So we start off with goals. And then to Pat's point, the comprehensive view of 24/7, when you've got licensed staff, physician, our frontline staff, which oftentimes are, they're trained in brain injury, but they're not licensed. So there can be like a layperson view there. So they might be less sensitive to little micro errors, but you put all those views together under a 24/7 watch for weeks to months, you're able to detect, how somebody's performing, the wins and the losses, the goods and the bads, and be able to capture that in documentation to show that, yes, maybe somebody had a good moment in their PT session, but then they don't have the energy to be able to get back into their own bed or take a shower later on at night. And so with that view, we're able to capture a lot of those type of notes and documentation through multidisciplinary roles. And then safety, if somebody, I'll use an example of like someone's having night terrors, persisting night terrors after injury or trauma. They might function fairly well throughout the day, in the home setting. They might need some support when they're on the community, if they're looking to do like some volunteer work, but then they come home at night, and then midnight, they're starting to have night terrors where they act them out in the middle of the night, and then they need someone to supervise them. For us, we're awake 24/7, we're staffed 24/7, we have experts. In somebody's home, a spouse may not wake up right when the person gets up, or they walk out the house, or things like that. So kind of risk goes up, and we're able to combat that risk by having our staff 24/7 on alert, trained up and skilled, and then also to observe behaviors, the good behaviors, the bad behaviors, and being able to get that on our documentation.
And Jimmy, do you want to, I know that you have patients that will come from multiple states away to the residential programs. Do you want to reference where where neuro rehab care has facilities?
Right.
Yeah, I know, like I said, it doesn't mean that I know you have people that come from 2, 3, 4 states away to be at your program for 2, 3, 4 months, depending on kind of their needs, but maybe let everyone know where the key facilities that you have are.
Yes. Yeah. So we're in Arizona, Scottsdale. We're in Louisiana, near New Orleans. We're in Kansas City. So kind of right on the border, Missouri and Kansas. And then you've got Iowa, and looking at coming to a state near you. So we're looking at other areas that we can grow, because there's just truly not enough services like these in the country. So, if we can be a solution for people, we want to be there. But we have been able to serve people as far on the East Coast, North Carolina. We're able to serve people far on the West Coast, out in Washington. So we can definitely accommodate various parts of where they live.
So,
Right.
With all the information that's kind of been shared, I didn't want our time to go away with, because this question goes and comes out a lot, just in various conversations, and that's, who is, appropriate? What does that person look like? You hear all the time, and Jimmy, you touched on this, severe TBI to mild TBI, and who's appropriate for a post-acute setting, and ultimately, how do those people get to you, through screenings and what you're looking for. I think that's important for people to kind of understand how people get to, the post-acute setting, and your area expertise.
Yeah. So it doesn't have to be all catastrophic. I mean, somebody that's had even, let's say, a mild brain injury or concussion, and sometimes I would go so far as to say that it hasn't even been fully determined yet. I mean, we might actually be able to pick up on that stuff ourselves through assessment, that there's some cognitive impairments or deficits that are persisting that possibly went undetected. In some of our settings, because we're licensed differently, we might see catastrophic injuries with spinal cord injury, or polytrauma. Like, those are certainly also, that's in our wheelhouse. So even though this presentation has been focused on the brain, that's not our limitation. We're able to apply some similar principles of practice to people that are trying to get back to their lives, whether it's cognitive impairment, physical impairment, psychosocial issues. So it's a broad net, but to reassure that our process is kind of what the proof is, through our assessment process, to determine if there's cognitive impairment, how is it impacting their life current day, what's their potential to improve, and then we do the treatment for that. I think that's a pretty general way to answer the criteria component.
Gotcha.
Pat's always on deck to help, screen and volley information to say, like, hey, does this one look like they might be appropriate for our program in Louisiana or Kansas or what have you? So we do that all the time. And then what was the second part of that one?
I think a key thing, I'm sorry, you go ahead, Kyle.
No.
Well, a key thing to that, and I think, again, that article, I don't know that you showed it, but you alluded to it, the article that's saying basically there are professionals saying, we really need to say mild traumatic, moderate and severe are those fuzzy categories. The reason being, we talked about the ambulance coming and the Glasgow score improving just because it took them minutes to get there, or they were dealing with a bleeding leg. And so Glasgow report by the time they get to the ER could be substantially different than it was at the scene of the accident, where it really is designed to be implemented. They some of these deficits don't actually really manifest until days later, when the brain, the chemical cascade, or the maladaptive behaviors start coming out. All the other things that take time, these things are often, they're just missed. And so that blurry line between, I mean, maybe it looked mild, but he still can't remember, walking down the hall, how to get back to his bedroom. Or, I mean, there's things that, or just, he's agitated now and it's not as the same way. So sometimes there's that blurred line between what is mild and moderate, or moderate. And so that's the component I know that is a challenge, is when people are trying to figure out what's going on with this patient. He just, or somebody might call and say, my client calls me every other day and says, hey, have you done this yet? And you say, yeah, I told you yesterday that I did that. Or, the mom says, hey, he's throwing the remote at the dog. And so there's these things that you just go, they're just behaving very, very peculiarly. And so we have to kind of step in and help figure out, is there documentation in the medicals that says what's going on? And can we help people to figure out what the right setting might be? And when it is appropriate for post-acute, I'm always glad to kind of give you a call and work through those things, because that's kind of where my heart is. I've been doing this for a really, really long time. And, I do imaging. I do a lot of different things at the earlier end, but really those candidates that are appropriate for post-acute, I feel like it helps so many people. So I appreciate the information that you are kind of sharing about that. So.
So, just to kind of put a finer point on it, if somebody, ultimately, sustained a head injury, and maybe they've gone and they've seen, a neurologist or a physical medicine rehabilitation doctor, and they've had neuropsychological evaluations or testing and things like that. I assume these are all things that you all use to determine kind of appropriateness, and then ultimately admit somebody into a program like yours for a particular length of time, which I assume varies depending on how somebody's progressing, whether it's 90 days or a year, so.
Yeah, exactly. And we do, this is a step in our pre-admission process, is to do a chart review, so we look to further kind of assess like what the needs are, and that gives us like kind of a front end review on somebody that would be appropriate for the program.
Perfect. Okay. Well, guys, I know that there was a ton of information that we kind of had to skip over to get to some of the meat. But like we talked about, I think we got enough interest where we can come back with a part 2 here and dive into a little bit more of some of the granular moments in post-acute, and kind of keep the audience going. So Ginger, we will stop at this point, and so we'll turn it back over to you.
Awesome. I do have some housekeeping notes, but before we end too, I'm going to be bringing Ted in because he's going to announce our 4 winners today, who are each going to win 4 bags of coffee each, which is kind of cool. So let me bring Ted in real fast. In the meantime, though, Jimmy and Pat, was there anything more that you guys wanted to talk about with neuro rehab care, as well as neuro care and the things that you guys do there? Was there anything else you wanted to mention while we have everybody?
You can find our website. Yeah, just go to neurorc.com, and you can learn more about our sites, and there's images up there. We're actually doing some nice upgrades to the site soon, and you can learn more about each facility there.
Okay, awesome. And I am going to email this contact page out to everybody after the webinar. I'm sure you probably want to adjust the slides a little bit. You can email me a copy and I'll send it out to everybody who's watching today as well. But I highly suggest you guys contact and stay in contact with Jimmy, Pat, Kyle, and all of our amazing partners with HMR, Fox-AE, and OnPoint. We are so lucky with you guys. I mean, this was such a great wealth of information that you guys shared today, and I really appreciate it.
Thanks, Ginger. Now, my contact information is on there, and so I coordinate a lot of things. Maybe they're appropriate for post-acute, or maybe they're not. But if it's around brain injury, I coordinate a lot of things at different levels, earlier, later, more severe, less severe. So if they want to, anybody who has questions or wants more information, they can reach out to me at that, info@NeuroCare Access, or call me at the 8334 TBI care, and I'll answer any questions, even if I don't have a fit for them. If I can just answer some questions for them about brain injury, I'd love to talk about it. So
Absolutely. Thank you so much, Pat.
great. Thank you.
And I see that our good friend Ted is with us to share some good news. Ted?
Yeah, it's always fun to see you, Ginger, and it's great to see you, Pat and Jimmy, Kyle. It's always good to see Patrick and Cody, and Taylor's one of my favorites. So it's just great to watch you guys all today. So that's lots of fun. And I have our 4 winners. So and it's from all over the country. So we've got Julie Hendricks from Louisville, Kentucky. We've got James Hunt from Rochelle Park, New Jersey. We've got Debbie Branson from Dallas, Texas. And we've got Oriana Minshaw from Sacramento, California. So I think we hit all over. So that was that was some great picks there. But congratulations on this this Leap Day webinar. So it happens every 4 years. So we're giving away 4 winners. So that's it's pretty cool.
That is so awesome. Ted, thank you so much, and congratulations to all the winners. We will be reaching out to you after this webinar to make sure that you get your freshly roasted coffee. And I love how I think our winner was from Seattle. Is that right,
Yeah.
Ted? On Tuesday.
Yeah,
So we were
last
like,
on Tuesday.
battle
Yeah.
of the coffee, like which one's better? We have to know, but this one has been
Take
pretty
that,
hot
Starbucks.
around the country. Everybody loves it. So thank you so much for doing this wonderful giveaway. And we do have a whole new set of webinars coming out in March. I'll be launching those in the next few days. So keep an eye out on connectionology.com, and you'll have another chance to try to win. So Ted, thank you for being with us. Thanks for everything that you do. And we're looking forward to the next one.
Awesome. Thanks so much, Ginger. This was great.
Absolutely,
much.
Kyle. And I just want to say to all of our speakers, thank you guys so much for being here with us today. We'll get together. We will come up with a date for part 2, and I'll announce it to everybody. And then we will be releasing this webinar on our Connectionology YouTube channel, as well as the HMR website. And you can actually go there. It's a great resource if you go to HMR's website, because they have some of our past webinars that they've done on TBI. Great webinars. I highly suggest watching those, but you can go and click on those links and rewatch those and then share them with your colleagues. Again, guys, thank you so much for being with us. And last but not least, I had to do this, but dun, 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 I had
See
to
you in
pop up.
Nashville.
Of
Nashville.
course, I had to do this.
Nice.
So John Romano is our chair. I think we've got 24 and counting. There's still more speakers being added, but it's an amazing agenda. We've got some incredible events. And like I said, I'm working with several people on developing some really cool sessions. But this is going to be an incredible program. And I'm not just saying that because we are helping organize it, but it really is special. And Kyle can attest that because he's come, and Pat, so all of you guys, so you know what I'm talking about.
Nashville's a fun town.
It
Yes.
sure is.
It's one of the better programs that's out there. We do so many of them nationally as a company, but this is obviously one of the biggest ones that we do all year, and it just got such tremendous support, and the information that comes out of it is just second to none. Like the speakers are always engaging, and it's incredible to be a part of. So we're looking forward to being in Nashville here.
Yeah. And I love that it's so manageable because it's a group that you can really get to meet. I mean, it's not going to be 1,000 people or something like that, but it's a great group that you really get to know everybody. And I don't know, it's incredible. So sign up, be there, and we will see you guys again on the next webinar. See
Thanks,
you guys
everybody.
later.
Thanks, Ginger.
Thanks for being here. Bye, guys.
Bye.
Bye, everyone.